All right, we can go ahead and get started. It's 7, so we'll get through this. I'm Tim Schaffner. I've given a version of this talk before at some point in the past, and so if some of this seems like you've heard it before, we'll just consider it review. But I brought it up to date a little bit. So, but if there's any questions while I'm going through this, please shout them out rather than wait until the end. You can't give a talk on GERD in an hour, the complete topic. It's impossible. So we'll obviously focus on the surgical aspect of it, but I always kind of like to talk about the pathophysiology. So that may be what really is mostly a review, because when you're operating on these patients, you really, if you don't understand the pathophysiology really well, it's difficult to tease apart what the right thing is to do for a lot of these patients. GERD's a big problem. 30 to 40% of the US population is a big number, and 20% of those people have weekly symptoms. And one of the things that we know about GERD is that from a surgical standpoint, it's vastly undertreated. 30% of the US population does not need to have a surgery. But the number of surgeries that we are doing in a year compared to the number of patients who would potentially qualify or have some quality of life improvement, there's a big difference there. It's complex disease. There's a big cost of disease, but the consequences of really severe reflux can be pretty bad. Barrett's esophagus, peptic stricture, or even esophageal cancer. And so the pathophysiology I'll really kind of touch on here. We know that the LES is not an anatomic sphincter. It's not a concentric ring of muscle that opens and closes. It's not the way that it's constructed, but it is still extremely important. It's the primary intrinsic mechanism, the body's primary intrinsic anti-reflux mechanism. It is a region of specialized smooth muscle, and it's organized in this clasp, or more commonly known as sling fibers, that creates this high pressure zone in the distal esophagus, and it creates that kind of flat valve effect that you see on endoscopy. It's tonically contracted at rest, and there's relaxation in response to a food bolus. The angle of His itself is not really seen in cadaveric studies, and so the thought is that anatomic feature is really created from this tonic contraction. There's a normal pressure gradient between the chest being at lower pressure than the abdomen, about 10 millimeters of mercury. So it's that pressure gradient that at rest the lower esophageal sphincter has to overcome in order to prevent reflux. And just a diagram of these are these kind of sling fibers here that cross from the angle of His, which you see here, down onto the cardia of the stomach. Those come up in another operation. In a Heller, you really don't have a complete myotomy unless you completely divide the sling fibers. And if you think of what's one of the major complications of a Heller, it's reflux. If you do a poem on somebody, a complete poem, their reflux risk is 40% or higher. That's primarily from dividing these fibers. So that's an intrinsic anti-reflux mechanism, and these are more of your extrinsic on the outside that are augmenting the effect that the LES has on reflux. The crura surround the esophagus, and obviously you get that pinch from an intact crura. If it has a hiatal hernia, that effect is lost. Intra-abdominal pressure can go both ways, and so if you have intra-abdominal esophagus and normal anatomy, that intra-abdominal pressure will compress above the GEJ and augment the sphincter. But if you have a patient who's obese and their intra-abdominal pressure is disproportionately high, or you have a hiatal hernia and you're not able to exert any compression on the esophagus, intra-abdominal pressure can actually worsen your reflux. The angle of His we kind of talked about, and the phrenoesophageal ligament is divided during a repair, but it's this continuation of the peritoneum that reflects from the anterior crura onto the esophagus, and when it's lax, it predisposes to a sliding hiatal hernia. Reflux is normal, so everybody has reflux. We don't necessarily treat reflux itself. Reflux in general happens when the pressures in the stomach exceed the pressures of the lower esophageal sphincter, and there are two conditions that happens under. One is this low pressure, lower esophageal sphincter, or a hypotensive LES. And the other is this transient LES relaxation. And these happen from a number of different phenomenon. GERD, or gastroesophageal reflux disease, is pathologic. And so that occurs when your reflux, physiologic reflux, reaches a point where the total amount of acid exposure or the patient's symptoms, or there's evidence of mucosal damage, that we begin to say that this reflux is excessive and some sort of treatment needs to be taken for that. So the first situation is low pressure, lower esophageal sphincter. It gets lumped into hiatal hernia a lot of the time because hiatal hernia is frequently seen in reflux patients, but not all of them. The GEJ gets displaced into the mediastinum. The chest is at lower pressure than the abdomen, and now you have a low pressure LES. Again, the frontoesophageal ligament is lax. The GEJ migrates cephalad. But we're not fixing hiatal hernias per se. There are a lot of people that have sliding hiatal hernias that don't have reflux. You can't do any better than no symptoms. And so we're not necessarily treating anatomy, we're treating symptoms or evidence of reflux damage. But with that being said, the larger the hiatal hernia, the more likelihood that they're going to have symptoms. Paraesophageal hernia, not really a component of this talk, but paraesophageal hernias, they do have reflux sometimes. But compared to like a type 1 sliding hiatal hernia, they're more frequently associated with obstructive symptoms, dysphagia, early satiety, etc. I've seen a number of people with almost their entire stomach in their chest and they don't complain of reflux. And you tell them, you might have reflux after this operation is over. And they're like, well, I don't have reflux now. So why would I then? This transient LES relaxation is just another mechanism to which patients can reflux. It's not understood all that well, but sometimes you do see patients on manometry that they have a normal LES pressure, but they still have reflux. Their Demeester score is still positive, and this is another mechanism by which that can happen. The spontaneous relaxation happens with or without a food bolus. Not really understood why patients with hiatal hernias seem to get them. Patients who are obese seem to have them more frequently than others. We'll talk about Strata at the end very briefly. The thought of why Strata works is mainly the thought that it decreases these transient relaxations. GERD episodes are postprandial, so that runs contrary to the thought that food acts as a buffer for gastric acid. And so the idea is you eat and your stomach is distended, you have these transient relaxations, your stomach then secretes acid, and that acid mainly floats on top of this food bolus. And so you get this acid that's secreted and it creates this pocket of low pH that's sitting on top of the food, and it's sitting close to the GEJ. And patients who have a low pressure LES or have a hiatal hernia, it presents a situation where they can have reflux. These GERD patients, as I said, have a more proximal acid pocket. This is just a diagram of the frontoesophageal ligament, and actually not really even a very good one, but it reflects from the diaphragm kind of down here below the Z line at the GEJ. So you have a patient in clinic, and so what are you going to do preoperatively? So this is the part that is a common oral board situation. History and physical, but it's probably all caps on the history and kind of lowercase letters on the physical. The physical is very rarely revealing for anything in these patients. Sometimes you'll see dental erosions in people with really severe GERD. If you actually do a dental exam on your patients when they come into clinic, good for you. I don't typically. But the history can almost always give you the diagnosis, or at least point you in the right direction. So clearly you're going to ask if they have clinically significant GERD. What's the impact of the GERD on your lifestyle? Do you have to sleep with 2 or 3 pillows? Are you able, what are your food restrictions? What are your medications? Do your medications work? Did they used to work and do they not work now? Describe your symptoms. Some people have typical versus atypical symptoms, where the typical is like your dyspepsia, heartburn, your regurgitation versus extraesophageal symptoms. They get reflux pneumonitis. I've had a few patients recently that they've been sent by pulmonology because their asthma is worsening and they can't find another reason why. The symptoms vary significantly from patient to patient. The triggers, my fellowship director loved to teach people about the common triggers. And so he described it as the Great American Breakfast. And so it was, you had your Bloody Mary. So your Bloody Mary has your citrus juice, tomato juice, and it has alcohol. So those are two. You have your coffee, caffeine. Naturally, you have a cigarette. You have your plate of bacon, so there's fatty food. And after all that, naturally you have a stick of gum, so there's peppermint. So those are the six big ones. And oftentimes, if you have the gun, gum. That's a great text. That's a great Texan breakfast. The gun, yes. Gunpowder is a well-known trigger for reflux. Peppermint gum. So if you get patients that are highly sensitive to those triggers, that also can kind of point you in the right direction. Some patients are, I think that the risks of long-term PPIs have been overstated, but there are certainly patients who say, I just don't want to take a PPI for the rest of my life. And that's not totally unreasonable. So these are the big 4 tests. These are the ones that if you're on your oral boards, you don't even think about it. You just say, I got these 4 tests. And there are some centers where the patients kind of get these as part of a pre-op workup before they even meet the surgeon. Everybody's a little bit different. I would say that getting all 4 of them in every single patient is not necessary. And there's really no consensus in the literature in terms of what the most ideal workup is for every patient. But the goal of the workup is pretty straightforward. You want to reliably diagnose GERD as a cause of the patient's symptoms, because there are other conditions that can masquerade. And you want to identify patients who are going to get better if you intervene on them. And so most people would say EGD is pretty essential component of the workup. EGD gives you a ton of information. You can assess for esophagitis, any strictures, Barrett's esophagus. You can biopsy eosinophilic esophagitis, gastric polyps. Yeah, you get a ton of information. You can assess for a hiatal hernia, what the flap valve looks like, et cetera, et cetera, et cetera. Despite all of that, 80% of the time it's normal. And so I have seen patients where they got an endoscopy and the endoscopist told them that the endoscopy was normal, so they don't need to worry about anything. And that's really not an appropriate approach to this. So the EGD will usually be normal, but it can definitely dictate the rest of the workup as well as your procedure choice. pH monitoring, typically the gold standard for GERD diagnosis, but it really, because it just gives you quantifiable evidence of acid exposure. This can be done either as a nasal probe or a Bravo, which is an implantable monitor by EGD that's wireless. But either way, the principle is the same. They get this recorder. It can be done for 24 to 48 hours. It produces a ton of data points, number of episodes, how long these episodes are, the percentage of time spent in reflux. They have a little button that they can push to say that they're eating. And so it'll record if their symptoms are postprandial. And all this spits out a number. And so most people end up just looking at the number, a Demeester score, and an abnormal Demeester score is 14.72 or higher. And if that's positive, they have reflux. Occasionally, this is done on PPI, which doesn't make any sense. It's kind of a useless test to be done on PPI. Patients generally have to be off PPI for at least a week when this is done. Manometry is also a really important test. It's something I've personally gone back and forth on. I've kind of gone back to pretty much getting it on everybody. It demonstrates pressure changes. You put this really uncomfortable probe. I don't know why anyone gets reflux surgery because this workup is so uncomfortable, but you put this really uncomfortable probe down their nose and they have to do 10 swallows, series of 10 swallows. And it demonstrates pressure changes at 1 centimeter points along the entire esophagus. And it, again, gives you a lot of information. The body of the esophagus, is it peristaltic? Is it not peristaltic? Is a hiatal hernia present? Does the lower esophageal sphincter relax? It gives you this DCI, distal contractile interval. It looks at the overall vigor with a swallow. The one thing to remember when you read these reports is the DCI that they present on the reports is an average. A DCI for a single swallow less than 100 is a failed swallow, less than 450 but higher than 100 is a weak swallow. But then there's a wide range of normal, like 450 to 8,000. And so the number they end up spitting out is really an average of their 10 swallows. So you have to keep that in mind when you get people who are borderline. You get someone who has a normal DCI of like 500, but they have like 5 failed swallows. Well, maybe that's not normal. But the reason I think that this is important is it can help exclude diagnoses. Achalasia can masquerade as reflux. Scleroderma patients are very poor candidates for anti-reflux surgery. They're typically aperistaltic. And so you really don't want to miss those people with the workup, which is kind of why I get it on pretty much everybody. It is necessary for Lynx, as we'll talk about. Historically, the degree of poor esophageal motility has been used to determine whether or not someone should get a complete or a partial fundoplication. That's kind of gone away, and I'll touch on that again too. Upper GI is I think of the 4 is probably the least helpful in most cases. A lot of times the patients come in from their PCM, they've already got one of these done. It does provide a dynamic evaluation, watching a swallow. It's good for paraesophageal hernias, especially if you suspect there's a component of obstruction there. You're concerned if someone has esophageal diverticula, et cetera. We do have what's colloquially known as the marshmallow bagel protocol that the radiology will do here, and it involves basically dipping a marshmallow in a bagel in contrast, and they take some bites and they swallow it. And they do that with prone views, and it gives you an idea of bolus transit. There is a validated protocol from that for USC. It can be used for motility evaluation. It's not as good as manometry. Sometimes if I'm in between doing a procedure or not, I will get this if the manometry is borderline to see if they have any transit issues. Some other things to think about preoperatively, so dysphagia. So a lot of these patients have dysphagia. And so why do they have dysphagia? That's the great question. So a lot of them, or the majority of them, have it because of inflammatory changes to the esophageal wall from reflux. And so many of these patients that have dysphagia will get better when you do your anti-reflux operation, but some of them won't. And so the one thing we know is that the best predictor of post-operative dysphagia is preoperative dysphagia. So despite what their manometry or upper GI findings are, this is a better assessment of whether they're going to have that complication post-operatively, which is why the tailoring of a procedure specific to manometry has kind of gone away. But in addition to that, Nissens are starting to become less and less common, which I'll talk about. Obesity is also a question we talked about. You know, high intra-abdominal pressure, obese patients are more susceptible to GERD. They have poor long-term control. They have poorer results with anti-reflux surgery. And so usually I will push them more towards bariatric surgery. If their BMI is between 35 and 40, I'll at least talk to them about anti-reflux surgery. I'll still kind of recommend a weight loss surgery, but I might still do it. But if they're at 40 or higher, I would not do an anti-reflux surgery. In the presence of Barrett's. So this is one of the reasons that the workup can be skewed a little bit. So if you do the EGD on a patient you think has reflux and they have salmon colored mucosa and you do the biopsies and they have Barrett's, they don't need pH monitoring. They don't need anything else. They're a candidate for surgery just by the presence of Barrett's. They have objective evidence of mucosal acid injury. It's an indication for surgery also because of the high rate of regression after the surgery. Now that, I don't honestly remember which study I got that from. The numbers that are quoted are kind of all over the place in terms of what the regression is, but low-grade Barrett's and low-grade dysplasia does tend to regress after surgery. They still have to have surveillance, even if it does completely regress, but the outcomes are really not bad. So who do we operate on? Number one is by far the most common. They I've taken BID PPIs forever and they don't work anymore and I'm miserable and I want to have surgery. And so then you do surgery. Non-compliance with medical therapy or people that can't tolerate PPIs are sort of unusual. Severe esophagitis or Barrett's, as I've said, those are both indications. A peptic stricture is an indication. Peptic strictures, people that have been dilated multiple times, usually if you operate on them I've dilated them in the surgery a couple of times and then post-operatively they don't reform the stricture after you do your anti-reflux operation. And respiratory symptoms is another one. And another thing in here that we did in fellowship a lot was on lung transplant patients. So basically, if you had any hint of GERD and you were in the workup for a lung transplant, you got a wrap preoperatively because it decreased the failure rate of the transplant postoperatively. So this is an area of real controversy. So how do you know that what you did was successful? Where is the goal line in terms of operating on these patients? There's really no agreement in the literature what that is. You base your treatment on symptoms primarily. And so if you have a patient that was horribly symptomatic and you do an intervention and they come back in and they're not symptomatic, but they're taking PPIs again, is that a success? If you have a patient who was horribly symptomatic and had Barrett's and you do an intervention and they're not symptomatic and they're not on PPIs, but their Barrett's progressed and their pH didn't normalize, is that a success? And so a lot of this is managing patients' expectations and proper patient selection. You're trying to pick the patients who you think are going to get the most benefit from this. I keep talking about the gold standard for some reason, and every time I bring it up, I say that there's not really a good gold standard for anything, so I'm going to say that again. Nissen in the literature is still considered to be the gold standard for surgical GERD therapy. That's probably going away, but that's surgical GERD therapy. So the majority of patients, 30 to 40% of the population, their GERD's controlled by PPIs. There are a lot of things written about the harms of surgical therapy, the complications of long-term surgical therapy versus the lack of harms from long-term PPIs. Another problem in the literature that really spawned some of the earlier GI-based papers, probably in the early 2000s, is that the technique of fundoplication is not standardized. And so if you get people who haven't really done them a lot, and then you compare the outcomes of those people from PPIs, they're not going to be very good. And so you also get this therapeutic gap of, patients who are partially controlled, they're better than they were on PPI and they would qualify for surgery, but long term, are you going to do more harms with surgery than just keeping them on PPI with minimal symptoms? It's hard to say. So the idea is that a gold standard implies that an intervention would be best for most patients in most scenarios, but that's not really true for GERD. 30 to 40% of the US population does not need a fundoplication, but there are many that do, and the treatment really has to be individualized to the patient's pathology and what their expectations are postoperatively. But say you're going to do a fundoplication. So these are Demester's 4 principles. And if any of you have done these before, you've undoubtedly heard us talk about these. So number 1, you have to restore 2 to 3 centimeters of intra-abdominal esophagus. The reason for that is both to decrease recurrence, but also, as I said, to augment whatever sphincter you're recreating with intra-abdominal pressure on esophagus that's above the GEJ. You want that sphincter, and so this is for a fundoplication, not really a Lynx, but you want the sphincter pressure to be about 2 centimeters and about 15 millimeters of mercury. That's about 3 times of resting gastric pressure, and it's about where you want it. The length of 2 centimeters helps keep it from shortening with gastric dilation. So if you imagine like a balloon and you're holding the neck of the balloon and then you blow up the balloon, and the more you blow up the balloon, the shorter the neck of the balloon gets. The kind of the same thing happens to the stomach with a food bolus or when it dilates. Protect the vagus. You can take the vagus in some scenarios if you need more length. If you're not able to get number 1, it's not really ideal. And the reason really is because there is a vaguely mediated relaxation of the fundus with swallowing. So if the fundus is more of a dynamic sphincter and it will relax with swallowing, assuming the vagus is intact. If you get a wrap where the body is used for part of the wrap and not the fundus, you can put them at a higher risk of dysphagia and wrap failure for that reason. And so, can you take the vagus? Yes. Will it still be, you make a floppy Nissen, will it still be okay? Probably, but it's more ideal, obviously, to keep them intact. And what does this all come down to is this idea that whatever valve that you're creating has to overcome the propulsive power of the esophagus, or the propulsive power of the esophagus has to be able to overcome whatever valve that you're creating. And so if you have someone with really severe dysphagia, it's probably better to give them a partial wrap rather than a complete wrap. But this principle kind of applies to Lynx and basically any intervention that you do. Those of you who haven't seen them, this one not typically done for anti-reflux surgery. It's done, some people will do it for a Heller, but traditionally these are the 2 that are done, and this is becoming much more prevalent than a Nissen now. I'll just touch on the complications. Early complications are rare. I mean, you don't really see these. Open conversion, I don't know that I've seen that. Perforation, most likely esophageal perforation. Pneumothorax is pretty rare. Capnothorax can be common if you get into the pleura during the case, but that is usually of little consequence. If you have a difficult redo operation, pneumothorax can happen, but also is not very common. The late complications get more of the press, wrap slippage or dysphagia. Dysphagia higher with a complete wrap than a partial wrap. Gas bloat, also more common with a Nissen than a partial wrap. And recurrence, which is a big issue. So recurrence is, in most studies, at around 20% at a year. It's around 40 to 50% at 5 years. But those are radiographic recurrences, not necessarily symptomatic recurrences. So I screen captured these next 2 slides off of this GERD consensus conference at SAGES a couple of weeks ago. And so this data hasn't been published yet, but they're just presenting it for the first time. And so they had a number of PICO questions that they did a pretty extensive literature search to try and answer. And so they answered this question, which I was surprised with, actually a moderate certainty of evidence, saying that a partial wrap should be favored over a complete wrap in adult patients with GERD. And these forest plots are a little bit confusing. Hopefully in the paper, they do a little better job. But in terms of recurrence of hiatal hernia, postoperative dysphagia requiring intervention, and gas bloat, those all favored a partial wrap. And I think the recurrence was the most surprising one, and that was borne out in multiple studies that the recurrence rate was lower with a partial wrap. Yes. Yes. Well, I mean, there were a number of studies there. My understanding was they meant to pay. Yeah. So on the next slide, this is where it's confusing. They say undesirable effects favoring partial. It's kind of a double negative. But these are the things that didn't really favor a partial wrap. And so it very, very slightly favored a complete wrap in terms of complete reflux symptom resolution greater than a year long term, and very slightly favored partial in terms of objective reflux recurrence. And so that based on all of that information, they favor a partial wrap in most scenarios. And I think that's kind of where the field is going. That's kind of what I've been doing too. One caveat I would say to this, you're looking for situations where you would do a complete wrap. There's some older data in 1999. There was Dr. Swanstrom had a study that showed toupee had a higher failure rate in patients with a Demeester score over 50. And here we see this slight trend towards symptom resolution and reflux recurrence with a complete wrap. And my guess is if you teased out all of the patients from these studies that had really severe reflux, Barrett's or Demeester over 50, I think that you would see a little bit more of a trend towards the complete wrap being better, but those are still really a minority of the patients. And so what I generally try to do is patients that have really severe reflux, I kind of try to push them towards a Nissen or a Lynx if they're a candidate for that. And this is really the reason why, is because I think in a certain patient population, in most people, you're going to benefit the long term. If their symptoms are going to be resolved, they're going to be fine. But patients with really severe reflux, I think that when you're weighing the benefits of complete symptom resolution, maybe being better with another, and dysphagia, gas bloat, et cetera, being better with another one, the really severe patients might rather opt towards everything that you have to do everything you can do to make sure that their symptoms go away and they don't come back. But again, that's probably a minority of patients, which is, I think, why the Nissen is becoming a minority of operations that's done. Another operation that's not done very often, or in my case, ever. This is a callous gastroplasty. So if you get in a situation where you can't mobilize, you've done everything you can do to mobilize the esophagus, but you've got shortened esophagus, you can't get the GEJ in the belly. What you can do is basically staple off this very proximal fundus and create this tubularized neoesophagus, and then you do this kind of screwed up wrap around it, and then magically everything's fine. Dr. Steve Demeester is a big proponent of doing this. I don't know anybody else who's a big proponent of doing this. He says his recurrence rates are much lower because of it. The problem is you're creating this neoesophagus that's really stomach above where your wrap is. And so it can continue to secrete acid and cause mucosal damage. And so these patients have to have surveillance endoscopy after your anti-reflux surgery because of that. So it's not an ideal thing to do, but I think if you have to choose between this and not being able to keep a wrap in the belly, go ahead and do it. But in most cases, if you're able to dissect all the way up, maybe even like to the pulmonary vein, you can usually mobilize the entire esophagus appropriately. Yeah, you just kind of pull it around like you do a normal wrap. It's going to look kind of weird, obviously, because you have like this. It wouldn't look exactly like a V like this, because you'd almost do it like a sleeve. You'd flip the stomach over and then do a bite, and then aim your stapler up the hiatus and take another bite. And so, yes, it will look weird, and you put yourself in a situation where you're doing your wrap with part of the body, depending on how much of a gastroplasty. But yeah, you just wrap it around like a roll. So Lynx is becoming more popular. It's been on the market for 6-7 years now, FDA approved. It's a great option for some patients, but the beginning of all these operations is the same: hiatal hernia repair, and then this is in place of a fundoplication. The only true contraindication is the metal allergy, and as the reps have told me, that's primarily actually from the sizer, because of nickel in the sizer, not necessarily the device itself. So there's only one true contraindication, but there are a number of inclusion criteria. And so the motility is a big question on this, right? So a wrap with functioning vagus is kind of a smart sphincter, and we'll say this is more of a dumb sphincter. So this is just a bunch of magnets, and your esophagus either generates the pressure to open the magnets or it doesn't. Fundoplication will relax in response to a swallow. So the motility is really important on this one. I probably should have unbolded the DCI for the reasons that I said earlier. There's not really like a number. Like if they're 240, they can't have a Lynx, and they're 260, they can have a Lynx, because remember, the DCI is an average. I would say if their average DCI is below 250, there's no way I'm doing a Lynx, regardless of their symptoms. But again, if you've got someone whose DCI is 400, but they've got 4 failed swallows, should they have a Lynx? Probably not. So the company will tell you, the company will actually tell you DCI has to be above normal, 450 or higher, 7 out of 10 swallows. They have to be of normal BMI, and they have to have a positive pH study. But I added the objective evidence of pathologic reflux or GERD. Again, if they have LA, C or D esophagitis, if they have Barrett's, the patients have reflux. They're candidates for surgery.
I have a quick question.
Yes.
Do you send people for metal allergy testing, or only if they say like they have a known allergy?
I haven't sent anyone for metal allergy testing yet. Most of the patients, if I ask if they've had a reaction to jewelry or something like that, they'll say, just give me a wrap.
Okay.
I guess if the situation where a wrap would be contraindicated and they really want a Lynx, then yes, I think that'd be a good idea. Yeah, I just haven't had to do that.
Thanks. Just curious.
Have you? Yeah. Yeah, that's probably something. I guess I haven't really encountered that situation yet where someone was really wanted a Lynx. But yeah, it's certainly reasonable to do. Early data for Lynx is equivalent to Nissen, really, in terms of the efficacy and safety. Again, there's another thing I should change. The dysphagia, they say, is equivalent to Nissen. I don't know about Dr. Hale's experience. It's way worse than Nissen. The dysphagia is 100%. And I would say probably I put about 80% of them on steroids post-op for dysphagia. They're on a regular diet, but they experience that dysphagia for the 1 to 3 months after the surgery, really, and it can at times really be difficult. They're not infrequently getting dilated, so it's not a minor thing to do to someone. But after they get through that 3-month period when the capsule really forms, they tend to do a lot better. Patient satisfaction is good. Oftentimes, if they don't require a big dissection, we'll do this as an outpatient. Explantation is about 4%, and the erosion is really low. Most of the erosions that are reported with this were earlier, smaller size devices that are not really on the market anymore. And I looked again for long-term data. There's really not 10-year data yet, and so that's the big difference between this and wraps for me. Is I can tell them what it looks like at 10 years. And this is still a bit of an unknown with Lynx. It might be better, it might be worse. We just don't know yet. It's based on the idea of this angel chick device, which is a historical thing. It's a non-dynamic reflux barrier, where the Lynx is a dynamic reflux barrier. This, unsurprisingly, as it was not dynamic, had a lot of erosion and was removed from the market. So I had a video before. I added this video of one of mine that, because I wanted to show an implantation if you haven't seen an implantation before. Fairly standard. But I'll mute that because no one wants to hear my commentary. This, in addition to just showing you an implantation, I think this patient actually shows really the value of this device. So this was a patient that was 30 years old that had an open duodenal switch like 10 years ago at Madigan. And she had, I think, 9 segments of non-dysplastic, 9 centimeters of non-dysplastic Barrett's at 30 years old. And so I've got to assume that her lifetime risk of progression of that Barrett's is exceedingly high. And so before the Lynx, what were your options for this patient? They were really just a really difficult open conversion of a switch to a bypass and hope for the best. And so, you know, I spared the 2 hours of lysis of adhesions, but she's still able to have a laparoscopic procedure and go home the next day, and, you know, came into clinic and she was doing really, really well, and was definitely a win for us. The other thing is some of the videos that are still posted, even from the company, represent the earlier experience with Lynx, where the idea was to do minimal dissection of the hiatus. And that has really gone away. And it's really, even the people that wrote those earlier studies have said, yeah, I mean, we don't do that. We do a complete dissection on everybody. I make my hiatal hernias a little bit tighter than most because I don't want recurrence. And so when you put this Lynx in, you're dissecting this window between the posterior vagus and the esophagus. The reason that you do that is to anchor the Lynx and keep it from migrating until the capsule forms. So you dissect that window and then usually put like a Penrose or something in there. I omitted the sizer. And then you bring the Lynx in through that window and clasp it. So also the most important thing, if you want to look good, is to just let the resident do the Lynx part, because the residents will get it in like the first try, and I'll like screw around for like, you know, 5 or 6 minutes trying to get this together, and they're like, I've never done it before, and they're like, oh, that was easy. So this little Babcock thing is like designed for this purpose, really. It just like goes right around the Lynx and just clasps it together once it's seated. And that's really it. And so it definitely is a lot easier than doing a wrap. Obviously, this patient couldn't have had a wrap, but it's definitely a lot quicker. So moving on. Nope. A couple of other things, mostly for historical perspective. So this is a Belzy Mark IV, which is the only really transthoracic anti-reflux repair that I know. I don't really think it's being done. Interestingly, it's called a Belzy Mark IV because Dr. Belzy thought very highly of himself, and he named his operation the same way that Rolls-Royce named new iterations of their car, Mark I, Mark II, Mark III. Must be he thought Mark IV was like the best it was ever going to get. But this is a transthoracic repair. The idea of the repair, not that dissimilar to a TIF. And I think there were some studies that it was being done with VATS, but I think that was mostly just to prove that they could do it. I don't think that I've ever seen one of these. This I've also never seen because this is my nightmare. So this is also historical. This is a Hill procedure. A Hill procedure is basically a posterior gastropexy where you're pexing the fundus to the preaortic fascia. My nightmare is to see one of these come in and need a redo because I don't really want to carve the stomach off of the aorta. And I have heard of a patient at a prominent medical center who died from that operation. There might be some value in something like this for people that have reflux after bypass, but now with Lynx and other options, I don't really think that it's necessary to go down this road. I'll touch briefly on these newer technologies that we don't really have here, but just in case you see them. So Strata, interesting, actually, we do have the Strata machine. It's sitting over at Wilford Hall collecting dust. And the GI guys just have really no interest in using it, even though I think there are probably a subset of patients that would really benefit from it. But it's involving radio frequency energy to hypertrophy the LES. That's how it works. It's also not rocket science. So you just put this thing down, you do an endoscopy, you put a guide wire down, you put this device down over the guide wire, and you blow up this balloon, and it has these little like spikes that enter into the submucosa, and you push a button and it delivers RF energy. And then you rotate it, and then you move it from the cardia, and then you move it to above the GE junction, and you do this like 22 times, and it's super boring. And then the patients go home, and then over the course of the next few weeks, you get this hypertrophy of the whole LES. And it doesn't have bad outcomes. It really does help in a certain subset of patients. They don't really get pH normalization, but their symptom scores, they do improve. TIF is another one that I think they do occasionally upstairs. Transoral incisionless fundoplication. There's only one device. It's called the Sofix device. And it creates this full thickness plication, fundoplication almost. It creates basically a partial wrap with a 3 centimeter valve. It's gone through several modifications, and it is typically a standalone procedure, but a combination procedure with a laparoscopic hiatal hernia has been described, which on further review might not be as crazy as I thought it was initially when I first read about that. But there's 2 different versions. So there's this TIF, 1.0, and it's commonly referred to as 2.0 for some reason. So, but the reason is that the original device, it created this fundoplication basically right at the Z line. And this one creates it a couple centimeters above the Z line, more closely approximating what an actual fundoplication anatomy is. The side effect profile is definitely better. So compared to RAPS or Nissen, these patients have virtually no side effects. They have no dysphagia, no gas bloat, no nothing. Well, the flip side of that coin is, does it actually work? Not really well. So this was the most recent study that I found from Ohio State, and there's only 57 patients. It's really their early experience. These patients' quality of life got a lot better. I mean, and that quality of life improvement was durable. But their post-op PPI use was high. 53% of patients, even at short term, were still on PPIs, and 3/4 of them were on it at long-term follow-up. And 1 out of 5 of them had total treatment failure and had to undergo a laparoscopic anti-reflux procedure during that time. So was this a success or not? You could argue that this represents a failure of therapy. You could also argue that this represents success in therapy if these patients' quality of life is better and it stayed better. They thought maybe that because before they had the procedure, their symptoms were not tolerated on PPI, and after they were tolerating it fine on PPI, and so it didn't bother them too much. But this was done with just the procedure not addressing a hiatal hernia. And so that's where some people have argued that maybe it's the best of both worlds if we do a hiatal hernia repair and we do this, and it limits the side effects. I think that has not been extensively studied as of yet. The last thing I want to mention, because this is a big thing, and you can't throw a stone in the B team clinic without hitting one of these patients. And reflux after sleeve is a major problem that we see all the time. And honestly, the numbers that I've been quoting people are probably too low. It's probably closer to 25 to 40% of people either have worsening GERD or they have new GERD, and up to 30% of them can have esophagitis, again, new postoperatively. There are definitely reports of de novo Barrett's at greater than 3 years post-op as well, which I'll talk about. The exact reasons these patients get reflux is not known, but there's likely a combination of factors. It is a higher pressure system, and so if you have a low pressure LES preoperatively, you create this higher pressure symptom. Now all of a sudden they're refluxing where they weren't refluxing before. Again, if you have a missed hiatal hernia as a cause of their low pressure LES, they're guaranteed to get reflux. And so you can't miss a hiatal hernia, or you're gonna be back to fix it. There's considerations in the anatomy. If you use too small of a bougie, or you're too tight to the incisura, or the sleeve kind of spirals, can create symptoms where they will reflux as well. And any combination of those things can land the sleeve patient back in your clinic. And so the current options are really conversion to bypass versus Lynx implantation for most of these patients. So this consensus statement was published in April of this year about using endoscopy pre and post bariatric surgery. And I'll just summarize the recommendations. The first two are not rocket science. We don't EGD everybody preoperatively, and the people that do are the ones that would get it just like the rest of the general population. Number two, also not real surprising, patients who've got bad esophagitis, positive Demeester score, positive impedance study. From a reflux standpoint, they should probably have a bypass and not a sleeve. It's not the only consideration, but if you're just talking about reflux, they probably shouldn't have a sleeve. The third one is the change. And so they're now recommending that all sleeve patients, regardless of symptoms, should be offered a screening EGD 3 years post-op and every 5 years after that, regardless of their symptoms. And the data is limited, but the reason why is because there were 4 case series showing endoscopic surveillance of sleeve patients. Only 646 patients, not randomized. The data is not great. You know, the methods are obviously different with every study, but the average de novo Barrett's in those cases post-op is 10.7%, which is certainly not insignificant. And so as of now, ASGE recommends screening for Barrett's in any population with greater than a 10% risk. So until better data exists, this is now the recommendation. So this is my last slide. So again, I just need to stop saying the word gold standard, I think, for some reason. Quoted in the literature, the Nissen is still the gold standard, but really now it's migrating more towards the toupee, because in the vast majority of patients, their symptom relief is preferable, is better with the toupee, and side effect profile favors the toupee. These emerging technologies, the Lynx, the TIF, the Strata, there are certainly patients that would benefit from those individualized approach, but the reality is that that individualized approach to these patients is what's necessary. There's really no single gold standard or single approach that works on everybody or is even appropriate on everybody. And so really knowing what all the different options are, how to apply them, who might be a candidate for them, is really necessary to treat these patients. So that's all I got. I think I'm out of time anyway. If there's any questions.